First of all, let me say that we're very happy that you're all here so that we can do this press conference. I think this last year has been a very successful year for the Ministry of Health, and we have lots of initiatives that we had embarked on at the start of the year, and we have been able to successfully complete many of these initiatives. I want to acknowledge the hard work of the staff of the ministry over the past year. I think because of their hard work that we have been able to accomplish so much in the last year. I also want to say that, as you would have heard the president on many occasions speaking about his vision for a world-class healthcare system, that the ministry has been working to deliver on that vision. And during some of the things that I will be talking to you about, I'll explain how we are working to achieve that vision before 2030. Many of the initiatives that we have, because of the nature of these initiatives, while you'll see some immediate results, but you will see concrete initiatives taking hold, and we will be able to demonstrate tangible achievements before 2030. And I peg that because in health, some of the initiatives that we have started, you wouldn't see immediate changes, but nevertheless, you will see things starting to move in the right direction. So starting off with some of the programs that we have in the ministry, one of the things that we've been looking at is in the area of chronic non-communicable diseases. These are diseases that affect people as they get older, and we have in particular focused on high blood pressure or hypertension and cardiovascular diseases. And in doing so, we have done a partnership with PAHO, that's the Pan American Health Organization, and we have initiated a program called HEARTS. And through the HEARTS program, we have been able to roll this out at more than 250 of our health facilities across the country. And in rolling these programs out, the idea here is that we'll be able to get better control of persons who have hypertension. So far we have been able to bring under that HEARTS program, where we're giving better medication to our patients, more effective medication so that they can have better blood control. We have looked at 31,855 patients that we currently have on this protocol. In terms of diabetes, and you know this is one of the big problems that we have in the country, we have last year, with the help of Mount Sinai, devised new guidelines for diabetics that include the way that we test persons for diabetes. And so we've been using a new test, which is the gold standard for diabetes. It's called the HbA1c, and that has now been implemented in about 83 clinics across the country, so that when someone go there, they'll be able to get their HbA1c, which is essential for you to understand what is happening with this diabetic patient. We have also introduced new measures because if persons do not control their blood sugar, then they can end up with complications. These complications include having eye complications, and if they don't take it in hand, they can go blind. If they don't manage their sugar well, they can end up with kidney complications, and eventually they'll need dialysis. And again, if they don't manage their sugar well, they can end up with amputations. So we are focused on managing people's blood sugar, and we currently have about 20,517 patients that are being managed at our various clinics and utilizing these new guidelines that we have put out. We have also trained many of our primary care doctors how to manage the complications of diabetes, which include training them to provide better foot care, better eye care, and better kidney care. In terms of cancer, as you know, this is one of the big challenges that we have in our country. And again, we have done quite a lot of work in terms of cancer care. The top cancers that we've been focusing on include cervical cancer, breast cancer, and for men, we have been looking at prostate cancer. And for both men and women, we have also been looking at colorectal cancer. Breast cancer among women remained the number one cancer among women. And for this year, we have identified at least 253 persons who were diagnosed with breast cancer. In terms of prostate cancer, we have identified 200 persons with prostate cancer. And in terms of cervical cancer, we've identified 107 persons. Colorectal cancer, we have seen about 98 patients with colorectal cancer. So these are, important for us to focus on how we can prevent, first of all, these cancers. And in terms of breast cancer, what we've been doing, we have been introducing mammography, because if you are able to do an image of the breast early, you'll be able to detect if there are changes. So we have one mammography machine at the public hospital, Georgetown, and we have worked with the International Atomic Energy Agency to get 4 additional mammography machines into Guyana. Those machines have arrived, and we are in the process of installing those machines. One would now be at New Amsterdam Hospital. So people in Region 6 and 5 would now have access to mammography for the first time. We are putting one in Lethem. And again, for the first time, people in that region would be able to access mammography. We are putting one in West Demerara, one in Sadi rather, and one in Linden. So the 4 machines, one New Amsterdam, one in Linden, one in Lethem, and one in Sadi. And these, by January, end of January, we should have them operational. So we'll be able to screen more persons to see whether we are detecting breast cancer. In addition to being able to detect breast cancer using mammography, a very important thing is to differentiate what type of cancer the person has. And so we'll be able to do what is called a fine needle biopsy. And through that biopsy, we can send that to the new pathology lab that we opened earlier this year. And we would be able to differentiate the different types of breast cancer that the person would have. That is important because the treatment differs. And prior to this year, we were unable to do those differentiations, and therefore the way that we were treating patients were not ideal. We have changed that now because we have these tests that we can do. In terms of prostate cancer, in addition to the usual tests that we will do, which is a HPV test, we have a PSA test rather. We have been able this year to scale up the amount of testing. And we have done, for this year, 13,688 PSAs in all regions of Guyana. And of the persons that we have tested, 2,607 of them would have come back with elevated PSAs. And of those, we were able to do 536 biopsies. And we have detected among the persons who we have done biopsies for, 126 of them having cancer. So apart from the people who come in routinely, at the number that I mentioned earlier, which was 200, We expect this number to go up because with these new tests that we have just completed, we have detected an additional 126 persons. Breast cancer, as I said, we have the new path lab that can give us the differentials. But for cervical cancer, we have introduced a program where we are doing HPV testing, and we have been able to do at least 9,962 tests this year, of which 1,755 are positive. So the numbers that we had recorded through our routine surveillance for cervical cancer, we expect those numbers to go up significantly, because as we do further investigations on the persons who are positive, we'll see a higher number. Colorectal cancer, we detect these persons when they come in with already significant changes, and it's hard to reverse it at that point. But we are now working on a program where we will be able to screen for colorectal cancer, and hopefully we can reduce the amount of colorectal cancer that we are seeing. So those are for the chronic non-communicable diseases. We have done other things, but I'm sure when you ask your questions, we can go through those. Another very successful program in the ministry is the school health program. As you would recall, most of what was done for school health would have been going into the schools and talking to the children about health education. We have changed that by now introducing a school screening program. And for this year, we have been able to screen 17,311 nursery school children we are checking their eyes, their ears, their mouth, and do a general checkup for them. And similarly, we were able to do 19,554 primary school students, and again, doing the same thing. Some of these students, once we find that they have a pathology, we are able to bring them into our clinics or hospital, and we are able to treat them. In terms of maternal death this year, we have had 14 maternal deaths. This obviously is not desirable, and we are working to see how we can reduce these maternal deaths. And wherever we identify maternal deaths, we are working with a team in those hospitals to make sure that we can prevent them. In terms of neonatal mortality for this year, we recorded 14 deaths. This is a significant drop from previous years. And we want to attribute this change or this drop in neonatal deaths to the improvements that we have at various facilities. We have introduced now, for the first time, basically, new neonatal intensive care units in 8 different hospitals across the country. This includes Mabaruma, Moruca, Suddy, West Demerara, Bartica, Linden, New Amsterdam, and Lethem. And this has, in our estimation, caused a decline in neonatal mortality. We have also been making significant progress on infectious diseases. In terms of HIV, the parameters that is used to look at HIV would include how many people know their status, of those who know their status, how many people are on treatment, and of those who are on treatment, how many of them are virally suppressed. And for this year, we have 95% of persons know their status. And that's the UNAIDS objective, to have at least 95% of persons with HIV knowing their status. So we have been able to achieve that. In terms of those persons who know their status and are on treatment, that has now increased to at least 75%. So we still have a percentage where we need to work on people coming into treatment, and that's something that the program is working on. And of those who are on treatment, we have 41% of them are virally suppressed, meaning that they cannot transmit the infection. And that's a good thing. But we want to work to make sure that everybody who is on treatment are now virally suppressed. So over the next year, this is something that we'll continue to do. We have introduced some new things, which include PrEP. We have been PrEP, meaning pre-exposure prophylaxis. So if somebody believes that they are at risk for HIV, then they can use these medications and prevent themselves from getting HIV. Those medications are available and they are at clinics across the country. We have also introduced something called self-testing. You can obtain those kits from us. And a lot of people have inhibitions about coming to our facility to check to see whether or not they're HIV positive. You can now pick up a kit and you can test yourself. And if you're positive, then you come into us and we'll be able to work with you on your treatment. TB cases, we have seen a decline in TB cases. Last year it was 438 cases. This year it has dropped to 331 cases. Malaria, we have been doing a lot more work in malaria. We have been able to diagnose this year 24,169 cases. We have distributed 109,523 bed nets. These are insecticide-impregnated nets. We have done more rapid tests, and we have been working closely with miners across the country so that we can train them, and in their mining camps, if people have fever, they would be able to diagnose them because we are giving them the kits and we are giving them the treatment. So this has been helping us to now get more people diagnosed rapidly, and we can treat them very easily. Hepatitis C, this is a new program that we have introduced. Prior to introducing this program, someone with hepatitis C, they literally would have lived out their lives, and a complication of hepatitis C would have been that they would end up with liver cancer. We are now preventing this because we are treating persons with hepatitis C. We have cured so far 44 persons, and we have another 68 persons who are currently receiving treatment. One of the programs that we have that we are looking at with PAHO has a program to eliminate a number of diseases by 2030. And we in Guyana, we have put our sights on 5 such diseases. This includes leprosy, filaria, Chagas, we have leishmaniasis, and worms. So for all of these, in terms of leprosy, we have decreased the amount of cases. This year, we recorded less than 15 cases of leprosy in Guyana. And for those persons who have contracted leprosy, the people around them, we have introduced prophylaxis so that they would not be able to get leprosy once they use the prophylaxis. In terms of filaria, we have already eliminated filaria from 8 of our 10 regions. As you know, this was a big problem in our country, people with big foot, but we have now eliminated this from 8 of our 10 regions. We have a problem in regions 4 and 3, and earlier this year, we introduced mass drug administration for these 2 regions, and we expect that next year, when we do the verification, that we would also be on the path to eliminating filaria from regions 3 and 4. In terms of Chagas, we have recorded 0 cases for this year. Leishmaniasis, we have had less than 20 cases for the year. And we are working on a school program where we would be able to eliminate worms in children across the country. For dental health, we have made significant progress. We have extended our dental health services across the country, and we have been able to treat a number of patients across the country, about 172,000 patients across the country, doing about 485,000 procedures for these patients. We have also introduced this year fluoride treatment, and we have been able to do fluoride treatment for 15,139 patients. In terms of looking at infrastructure, and new infrastructure, and new health centers and health posts that we have been working on, in Region 1, we have just completed the Imbatero Health Center and another health center at Big Creek, and these will be commissioning shortly. And we expect that early in the new year, we will be able to complete Tassawini and Five Star, which are currently, they're now finalizing some things on these two health centers. So we expect by the first half of next year that we'll have these operational. For this year, in Region 4, we have commissioned Swan Health Center on the highway, and we expect very soon in the new year that we'll commission Mount Repose Health Center. For Georgetown, we have just completed Northeast La Penitence Health Center, and so early in January, we should be able to commission that health center. And we are currently working on the number 1 dispensary, so by the end of next year, we should have that up and operational. In Region 5, we have commissioned a health center at Lakeville. This is in the Mahaika Creek, and we have completed one at the San Jacob in the Maikoni Creek, and we have another one that we have just completed at Abari. The one at Abari will be opening this in the first quarter of next year. In Region 6, we have completed Chesney Health Center and Canefield Health Center, and again, these are now operational. In Region 8, we have started the construction, and this is slated for completion by early next year at Kurubung. And in Region 10, we have commissioned Blueberry Hill Health Center and Mabura Health Center, and in early next year, we will commission the Falmouth Health Center. New hospitals, as you know, this year, we were very busy looking at our new hospitals. The president has been able to turn the sod for a new hospital at Maruka, one at Keto, and one at Lethem. So these are 3 new hospitals that are being built, and they're being funded by the Inter-American Development Bank. We also wanted to do the Camarang Hospital, but unfortunately, when we went out to tender, nobody bid on the Camarang Hospital, so we have to go back and retender that particular hospital. For New Amsterdam, the hospital that we're building at New Amsterdam, we are currently at the stage where the contractors are piling, doing the foundation for the hospital. And once that is completed, we expect that to be completed by January. They'll start putting up the infrastructure of that hospital. As you know, that's going to be a 220-bed hospital. It's going to be a general hospital, and it would also have things like MRI, and we'll be able to do cardiac surgery and so forth there. In terms of the mother-to-child hospital at Ogle, we expect that by January, the facade would be completed, and they would start doing installing the mechanical and electrical equipment going forward, because this would be essential for us to move that hospital forward. Other regional hospital, as you know, we have been working on doing the Lima Hospital, the Dikendron Hospital, the Diamond, Enmore, Bath, and of course, the number 75 hospital. All of these would be completed early next year, and we are hoping that they can be commissioned before June of next year. So that's the plan that we're working on. We also started this year the construction of 2 nursing schools. One is at New Amsterdam and one is at Suddy. And we expect that by next year, these nursing schools would be substantially completed and operational. One of the big challenges that we have in the health sector, as you know, is with personnel. And since we came to office, we have been able to train at least 2,079 medical professionals in different regions of our country. And they have all come on to the payroll of the ministry and have been working and performing. Next year, we intend to graduate. Once they pass their exams, we'll be able to graduate another 3,050 persons in different specialties of medicine. And while we would graduate that 3,050 persons, we currently have another 3,740 persons in training. And next year, we intend to take in another 3,000 persons in various programs. We have to facilitate training. We have been decentralizing the training. So in all regions, we now have decentralized programs. And we have also added what we call simulation centers, where when people are trained theoretically online, they will then be able to come to the simulation centers to do practical training. And we have so far constructed and operationalized 9 simulation centers across the country. The only region that doesn't have a simulation center right now is in Regions 8. And that by early next year, we'll be able to put that in place. We also have been working with a number of partners to enhance how we train our medical personnel. And we have a strong partnership that is funded by the Pan American Health Organization, and that is being implemented by the University of São Paulo in Brazil. Through this partnership, the professors from that university in Brazil has been coming to Guyana and working with our training team so that we can have the hybrid nursing program. And they have been doing this for the past 2 years. So this has been a very important collaboration, and through this collaboration, we have been able to expand nursing training. That's why we have so many nurses currently in training. We also have a collaboration with McMaster's University, and through that collaboration, we would have at least 30 doctors being able to pursue fellowship training at McMaster's. So far, we have at least 5 of them that are currently undergoing training at McMaster's. We also have fellowship training with Northwell. And as you would have seen recently, one of our doctors at Georgetown Hospital was trained in urogynecology and is back and now serving the country. We have also been collaborating with York University in Canada, and we have trained 3 cohorts of persons, 2 of those cohorts in health administration, and that would be approximately 60 persons. And we now have, we have also trained 30 doctors in physician leadership, meaning that the doctors would be able to manage their different wards better, or departments better. We also signed an agreement with the University of the West Indies, and next year you'll see that we'll start the implementation of 3 schools that would be managed by the University of the West Indies. This would include a school of medicine, a school of nursing, and a school of pharmacy. So all of these would help to enhance our training capability in the country. In terms of vaccination, we continue to administer close to 19 antigens to our children. And over the last year, we have added 124 new refrigerators to the system. 21 health facilities for the first time being able to get refrigerators. And recently we have added 2 vaccination boats as well. We have also added 2 walk-in freezers, one at the central, at the Kingston Bond, and another one in Linden. We also have been expanding telemedicine, and we have moved from 59 sites now to about 89 sites. So this is something that we're going to continue. Our intention is to have all our health facilities in regions 1, 7, 8, and 9 being connected and being able to access telemedicine. And then we'll do that for the facilities here on the coastline. We also have some partnerships with a number of international organizations. One big partnership that we have is, of course, with the Pan American Health Organization, and we have done quite a number of different things with PAHO, including looking at planning of health manpower, including looking at elimination of diseases. They have given us technical support in rolling out programs like HEARTS, and we continue to work with them in many areas of public health. This year as well we were very successful in mobilizing resources. We wrote a proposal to the Pandemic Fund. As you know, the Pandemic Fund was established after COVID to look at how countries can better prepare for future pandemics. And the fund right now has about 1.5 billion US dollars. And they have been doing calls for proposals from different countries. This year, when they put out the second call, we put in a proposal asking them for 15 million US dollars. And we were very successful with that proposal. So Guyana now has access to 15 million US dollars, which by March next year, we should be able to start accessing. We are doing this particular program with the World Bank, and the World Bank would be adding another 7 million US dollars. This program would focus on surveillance of diseases, both among the human population and animal population, because we want to make sure that if there's a disease in the animal population that jumps over into the human population, that we'd be able to detect that. It would also focus on enhancing our laboratory capacity, and part of this would go to enhancing the work that we are able to do at the National Public Health Reference Lab. We'll be investing approximately 2 million US dollars in the National Public Health Reference Lab so that we can move that lab up to a level 3 facility, and we'll be adding a new division to that lab where we'll be able to do molecular surveillance. This is absolutely essential if we want to work with viruses and understand the types of viruses that are circulating. Already for that lab this year, we have worked with PAHO, and we are able to do influenza and virus tracking so that we can tell you the types of viruses that are circulating in Guyana. This year, we have been able to successfully check a number of our patients and detect the type of viruses that are circulating. And very soon, we'll be certified by PAHO as one of the collaborating centers in influenza. We continue to work with the Global Fund, and with the Global Fund, we have grants in malaria and HIV. We are also partnering with a number of academic institutions, which includes Harvard, York, McMaster's, Northwell. They are both academic and a hospital, Mount Sinai. And we have also worked with the Tony Blair Institute, and they have assisted us in drafting the new digital health strategy for the ministry. So under that strategy, we have a number of things that we are doing, including building a new department dealing with digital health in the ministry. We'll be doing informatics. We'll be rolling out new surveillance software. Uh, on one hand, we are also start the rolling out of the electronic health records, which is starting at the Georgetown Hospital early next year, and of course, the expansion of our telemedicine. So for next year, what you can look forward to is us commissioning at least 6 of the new hospitals. That is Lima, Dequendren, Diamond, Enmore, Bath, and of course, number 75. And with these new hospitals, we'll be adding 450 new beds. We'll be adding at least 12 new operating rooms. You will have 6 new accident and emergencies that would be operating on a 24-hour basis. We would be adding a new imaging section for each of these hospitals. So for the first time, we'll now have at least 6 CT scans operating on a 24-hour basis across the country. New 24-hour laboratory services, new delivery rooms. So these hospitals, as they come into being, would be able to provide these types of services. In terms of other public health initiatives, we'll be expanding the school health program, where we would be adding or doing work in secondary schools as well. We'll be expanding the chronic non-communicable disease program, where this year we'll have a focus, in addition to cancer and diabetes, hypertension, cardiovascular diseases. We'll be looking more closely at kidney diseases and respiratory diseases, because we want to work on preventing chronic obstructive lung diseases. So this is an area that we'll focus on in the new year. We would also be looking at digital health and innovations, as I said, and our focus there would be rolling out new programs where we can now be able to do patient records. And in human resources, we'll be expanding our training in a number of areas so that we can meet the growing demands of our healthcare system. So I'll stop here for the moment. I just, again, want to thank all the staff of the ministry for the work that they've been doing. And we continue to expand and grow the system so that, we can provide better health care for the people of Guyana. Our objective is that we want to make our population one of the healthiest population in the region. So I'll stop there, and I'm sure you have questions. We'll take your questions.
Good morning. I have several questions. Should I go through all of them?
Yeah, go through them. Let me write them down as you go. Let's go.
Right. So does the ministry have a viable plan for the staffing of its new hospitals? And can you say how many specialists, doctors, and nurses are needed, and where will they come from? The GPNC yesterday said it needed about 700 nurses. Can you tell us where those nurses will come from? And does the ministry have any data on how many locally trained nurses migrated last year? Also, can you say which of the new state hospitals will be completed first, and are they on schedule? Also, the president recently complained about the pace of work on the maternity hospital at Ogle. Can you update us on the progress of that project? And has the ministry applied liquidated damages or any other penalties to the contractors? And can you say overall what the number of maternity deaths in the country was, and how that compared with last year? Also,
Good.
can you say what the total number of dengue cases was this year compared to last year, and how many deaths there were? Also, how many COVID-19 cases were detected here last year? And can you speak about the plans to eradicate malaria in the hinterland? Can you also say what was the estimated amount of expired drugs in the health system this year compared to last year? Also, what measures are the ministry taking to limit new HIV infections? Can you also say what age range in the country sees the most cases of HIV? And lastly, does the Organ Transplant Act cover stem cell therapy?
That's quite a mouthful.
Well, I didn't hear.
Good. Anybody else?
Yes, yes.
Uh,
Good morning, Christina with Trainers. In 2022, you said that your government aims to end AIDS by 2030.
mhm.
Can you relate on some of the progress that you have seen since? Also highlight some of the strategies the health ministry has initiated to tackle the sickness, and are you, with the progress that has been seen, are you
Mhm.
confident that indeed Guyana is on board to end AIDS in 2020? And lastly, have you recorded any deaths from malaria this year? If so, how much? Thank you.
All right. All right, we can go through them. Okay, so let's start maybe with the HIV one. So the UN AIDS got a projection that by 2030 they want countries to be able to end AIDS as a public health problem. That doesn't mean that there wouldn't be any AIDS in the world, but it wouldn't be a public health problem, meaning that you'd be able to treat it like any other disease, manage it, there wouldn't be a problem, right? So that's what we are aspiring to do. And their measurement is that they have, to measure whether you have success, they're saying by 2030 that every country must be able to achieve 95, 95, 95. The first 95 meaning that of all the patients in the country, 95% of them must at least know their status, whether they're positive or negative. So once we know that, of this 95 set of people, 95% of people who know their status, we want 95% of them to at least be on ARVs, the treatment. So what we have been working on is to make sure that we get as much people who know their status on treatment. For us here in Guyana, that number is 75. 75% of the people who know their status are on treatment. So that's why we have a gap. We have the medication, we have all the things to treat people, but we need persons who know their status and they know that they're positive to come in for treatment. It's not something that we can compulsory do. They must want to be able to get on treatment, right? We can't force them. But we have several clinics across the country. We have all the medication to be able to treat them. We have standard protocols how we're treating people, and those things are available for every patient that we have. Now, for those who are on treatment, the success for treatment is that we want to make sure that we don't detect any virus in them. And in the past, that would have been a problem because the country did not have a machine to do viral loads. And at the time, if you had to do a viral load, it would have been very expensive, probably about 60,000 Guyana dollars to do a viral load. So this was a problem for most patients. We have corrected that because we have now bought a machine to be able to do viral load in the public sector. And we are now offering those viral load free of cost to patients, right? So by doing that, we now have at least, I think, 41. We now have 41% of those who are on treatment. We can't detect any virus in them. That is very, very significant because if we are not detecting the virus, that means that person cannot transmit HIV to another person, right? So our aim is to take that up as high as possible because then it reduces transmission. And therefore, over time, we'll see this go down. So to answer the question, yes, we believe that we are on track to meet that UN target, UNAIDS target by 2030. We believe that we are on track. Now, some of the things that we have been doing, there are persons who are at high risk because of their behaviors, right? So one of the ways that you can help people to minimize their risk is you can give them these pre-exposure prophylaxis. So if somebody believes that they are at high risk because of their lifestyle, they can use the medication, and if they have unprotected sex, then they would not get HIV because they're using pre-exposure prophylaxis. We have been able to offer that. In the past, that was only offered to what we call serodiscordant couple, meaning that if one partner was positive and the other one was not, then you offer it to the partner that was not. And that was just a small group of people. But now we have opened it up, and that's based on the recommendations of all the organizations working in HIV, that you should open it up to people who are at risk. And so we have opened that up, and so anybody who feel that they're at risk, they can access these medication and use them. So that's one measure that we have put in place. The other measure is that somebody can be positive, but they're afraid to come into the facility. And because they're not coming, they don't know their status. And so one of the other things that we have introduced is do the self-testing. Get a kit and test yourself. And so that has been working as well. And then if you're positive, then you come in and we work with you and make sure that you think. What we have seen is that there have been a decline in people dying from HIV. So I think for this year, if I remember correctly, we probably had less than 10 deaths directly from HIV. Most people who would die now, they're not dying from HIV, they die from a chronic disease because they're able to live longer and they die from something else other than HIV. And that is a testimony to the types of treatment that are now being offered, right? So yes, we think that we are on track, and we are working to make sure that we continue doing this. I think your question was what age group? We're seeing new cases. That would be between 20 to 30, that age range. Most of the cases we are seeing in that age range. And that's not strange because this age group is where you have more sexually active people, right? So that's the age range that we are seeing. All right. In terms of the one with the stem cell, so the legislation that we passed in 2022, that piece of legislation, it has broadly 3 broad areas. One, it provides for transplant of organs, tissues, and it also, there's a section there that also talks about transfusion. Because prior to this piece of legislation, there was nothing that dealt with transfusion, right? So we are now able to cover the blood bank. And the third component of that legislation talks about regenerative medicine, meaning to use things like stem cells. So that is covered in the legislation, and we have been working to bring that legislation to life. We have a transplant agency that has been set up, and that agency has worked with several partners, both locally and internationally, to put a number of regulations in place so that we can monitor and have these things done to international standards. A partner that has been working with us is the DTI, that's the Donation Transplant Institute in Barcelona. They have done quite a lot of work with us. And through PAHO, their division in Washington that deals with transplant. So we have gotten a lot of help from these two agencies. And through that help, we had experts from Barcelona came to Guyana and worked with the team here to build out a lot of regulations. So those regulations are now available, and that's the regulations that the agency is now using. In addition to that, the agencies has been working with the hospitals locally to certify them to be able to do transplant. As you know, we are doing live donor transplant for kidneys, and they have been looking into the possibility of us doing deceased donor transplant. So that is something that we've been working on.
I want to follow up on this. Is any hospital in Guyana certified as yet?
Only one, that's the Georgetown Public Hospital. The others, there are others in the private sector that have indicated that they would like to be certified, and they have been told the requirements, so they're going through that process of meeting those requirements to be certified. So by next year, I'm sure that we'll have others who would be certified. That covers your
First question.
right. Staffing. Let's come back to staffing. So the ministry, we have worked with PAHO, for example, and we have done a staffing plan of how many people we would need to address some of the migration that we have, and also to address the expansion that we are doing. And for each of the new regional hospital, for example, we have quantified how many people we need. I don't have that here with me, but we have a quantification. So we have how many specialists, how many registrars, how many GMOs, how many nurses, how many midwives, how many laboratory people. All of it we have quantified. And we have been working to train persons locally to be able to meet those demands. That is why we have started this hybrid program. And through the hybrid program, we have been able to enroll at least 1,100 persons in the first batch. This year, we took in another 1,000 persons. Next year, we'll take in maybe another 1,000 or so. The challenge that we have is that to train a professional nurse, it takes at least 3 years. So even though we start these programs, we are not going to get a professional nurse until 3 years. So we have started, and you will see a lot of the fruits, the training that we are doing, that we'll start seeing those persons by 2026, right? Most of them would start graduating by 2026. While we are waiting on those persons to graduate and we continue to train and so forth, we'll have a gap. And in that interim, we'll have to look at how we can fill those gaps. And that would include bringing people from abroad to fill those gaps. So just like how we are losing persons to migration, we would have to explore possibilities of people coming in and working in Guyana, those who are desirous of doing so. And so that's a program that we've been working on. And we intend by next year, when these 6 hospitals are ready, they'll be fully operational because we have made plans to staff them both with local and overseas staffing. And so that would be fully operational by the mid of the next year.
All of these persons that would be needed, would they be coming from Cuba, or have you explored bringing health professionals from other countries also?
we are exploring several options. And whichever is going to be better for us, that's what we'll pursue
And can you say when these persons might start coming?
when we get closer to the opening of the hospital. So one is local staff that, because remember, let's say number 75. Number 75, we're replacing Skeldon Hospital with number 75 hospital. So there's existing staff there, right? So those staff would come across, plus we'll supplement because they'll be doing more services now. Similarly for Fort Wellington. Fort Wellington staff would go across to the hospital next door, Bath, and so we are supplementing. Diamond, same thing. Diamond, the Diamond current hospital that we have would go to the new facility, and then we'll supplement. So it's not all of them that we need totally new people, right? So we'll be supplementing. So that's staffing. So we have been working on making sure that we have the staff in place, and we continue to train and expand training so that we can meet the needs of our facility. We are also training a lot of nursing assistants, and that's a shorter program. It's a year, but they would work under the supervision of a nurse. And so, again, we'll have about 1,000 nursing assistants graduating next year, and they would be in the system. In addition to that, we have also relooked at the work that a nurse is required to do. We have started that exercise at the Georgetown Hospital because a lot of time the nurse is doing a lot of non-nursing duties. What do I mean by that? Sometimes a nurse goes from the ward to go to the pharmacy to pick up the medication from the pharmacy to bring it back on the ward. That's really a non-nursing activity, because what we need the nurse to focus on is to do things for the patient and to be there for the patient. So we have had a review done, and we have changed what the nurses are supposed to do so that they focus more on the patient and provide better nursing care. And those non-nursing things, we are employing a new category of people who can go pick up medication, bring it to the ward, and so forth, so as to minimize the things that you want the nurse to do. So that we have started that at the Georgetown Hospital, and we are going to expand that to the other facilities as well. So nurses must do, the core things relating to nursing rather than do all kinds of other peripheral things. So that's how we are addressing some of the issues relating to staffing. In terms of I think I touched the second question you asked with something about the new hospital, huh? What was that?
Which of the new state hospitals will be completed first?
Oh, right, good. So for the 6 hospitals that we're looking at, the ones that, in my view, would be completed first would be Diamond, Enmore, and Bath. I think by March of next year, these should be completed. And the other 3 should be completed by June next year. So I think these 6 would be ready before the first half of next year.
Are they on schedule?
They're on schedule. In terms of the maternal and child health hospital, that one, and you ask about liquidated damages and so forth. So that contract officially, they have until October of this year to deliver that hospital. And we have been working with them to see that they can expedite and recover from some of the delays that they've had in the past. So we have been working very aggressively with them. We'll see whether they'll be able to meet their contractual deadline by October. If you go there now, you would have seen substantive progress would have been made. They have more people working on the site. They have additional shifts that they have put in place, but it left to be seen whether or not they would be completed by their contractual deadline. Only after that, then we'll be able to impose the penalties that are in the contract. In terms of maternal deaths for this year, we have had 14 maternal deaths. And for those maternal deaths, we have had had one person dying from Region 1. We had 4 persons dying in Region 2. We had 3 here in Region 4, 2 in Region 6, 1 in Region 8, and 3 from Region 10. We had 0 maternal deaths in Regions 3, 5, 7, and 9. So that's commendable. And this has declined slightly. I think last year we had 15 deaths. So we continue to work on this, and there are a number of interventions that we have been doing, because in the past we noticed people would die from postpartum hemorrhage, especially in the interior of our country. We have run training. We haven't had anybody die from postpartum hemorrhage. So these are other complications that people are dying from, and we've been working to reduce these. So that's maternal deaths, right? Dengue cases. This year we diagnosed about 10,000 persons with dengue. And of those 10,000 persons, we had I don't have the number for hospitalization, and I don't think we've had any deaths. But I don't have those numbers with me here. Now, with dengue, one of the interventions that we have put in place, we have better diagnostics available. So all our regional hospitals, we now have capabilities of doing the dengue tests, so they don't have to send centrally. We also we'll roll out a new program where every NDC and every village council would get from us these fogging machines, and we will train them how to do fogging. So that's something that we'll be doing in the new year, and hopefully we'll be able to see a decline in the cases. Right now, a lot of the NDCs and so forth, they rely on the ministry vector-borne team to go out to do the fogging. So what we want to do is decentralize that, train people to do it so that they'll be doing it in their own community. I think we are buying close to 200 and something fogging machines, and we'll be training people to do that. We are also looking for COVID cases. We didn't record many, not because there aren't COVID cases. So there are still people who would get COVID because the virus is still circulating. There are different mutations of the virus, but unfortunately, a lot of people don't come in to be tested. So if they don't come to be tested, then we wouldn't be able to say how many cases we have. The National Public Health Reference Lab, we are now able to take samples from patients and be able to do the sequencing for the sample. And now we can also tell what are the variants of COVID that are circulating. But again, if people are not coming in, then we wouldn't be able to do the testing and give you a authentic number of how many cases we have. Malaria, we have had about 24,000 cases, and these are predominantly in regions 1, 7, 8, and 9. And as I said, we have been doing a number of interventions, including giving out the bed nets. That has helped to bring down cases. But I think more importantly, what we're seeing is an association between malaria and gold mining activities. And because we have seen that correlation, we have been working with the gold mining associations to train miners on how to do the case detection and how to treat. And so that's an ongoing program that we have, and hopefully that would help us to reduce the amount of cases. In addition to that, about a month ago, the Ministry of Health, we had a consultation. We are coming up with a new malaria plan. In the past, our malaria strategy would have been to look at how we control the amount of cases that we have of malaria. And so that was our approach for, I don't know, maybe 3 decades, right? We want the new plan that we are developing is looking at how we can eliminate malaria from Guyana. So no longer do we want to live with malaria. We want to eliminate it from Guyana. How are we going to do that? We'll target the endemic regions, which is regions 1, 7, 8, and 9. We currently, in partnership with Harvard, we are looking at region 9. And we have in region 9, there's a specific area where we are seeing the most malaria cases. And we are putting in some interventions in that area. And we are very confident that within a year to 2 years, that we will be able to reduce significantly the amount of cases of malaria in region 9. And then we want to use that and replicate some of that into the other regions. So that's one approach that we have with the team from Harvard. There's another approach that we are right now finalizing the technical details on. For malaria to spread, you have the people who are living in these endemic areas, they are the host. So they have the parasite in them. And we want to be able to give each person living in these endemic area, pretty much like what we did for filaria. We'll give them a medication, and that medication would kill the parasite within them. And once that is done across the board, then we would be able to successfully eliminate malaria in these 4 endemic regions. So that's something that we're working on. We are right now examining the technical feasibility of doing so and the cost of doing so. And once we have those numbers, then we'll look at implementing that particular program. So that's a work in progress that we have. But we are confident that we can make a significant change in how we approach managing malaria in Guyana. In terms of expired drugs, unfortunately, I don't have how much drugs would have expired this year, but we can get that for you later on. Good. Next person.
Yes, Shamar, Mr. Guyana Council. Just 2 questions for me.
Mm-hmm.
We've been hearing about the electronic health records and digitization of the systems at the hospital for quite some time.
Mm-hmm.
Earlier this year, I remember bids were being evaluated and so on.
Mhm.
What stage are we at currently in that whole thing? And my second question, the Mount Sinai HES and Government of Guyana partnership. Can you expound on some of the tangible outcomes or achievements of that partnership? Because we haven't really been hearing much about that.
Okay. That's it?
Yeah.
All right, so electronic health records, we have made some progress. As you know, this is an IDB funded project. And it took us quite a while to get through all the hurdles. You would recall we went out to a public tender. We got 14 expressions of interest. And then the team, when they did the evaluation, they were looking at 98 different technical parameters. They narrowed that down to 4. And of that 4, we have a selection of 1. And that contract is now being awarded. That's a UK company that won the bid, and that bid, I think, is for 3.3 million US dollars. The records, we would start with phase 1 at the Georgetown Public Hospital and its satellite clinics. And then once that is successfully completed, we would be able to then roll it out to the other hospitals. Phase 1, we expect that to start early in the new year because we've gotten past all the contracting part of it. So now it's getting the company and start doing the implementation. So that's where we are with the electronic health records. In terms of our Mount Sinai partnership, through this partnership, there were a number of things that were done. One component that we looked at was improving the Georgetown Public Hospital. So there was a team from one of Mount Sinai's hospital that was working directly with the Georgetown Hospital to improve patient outcomes and also to improve management efficiency. So things like looking at waiting times, looking at lean management, where we don't waste resources and so forth. And the program that I mentioned earlier, where we're trying to look at more core duties for nurses versus the other things. That was a study that was done by Mount Sinai. So based on that study, we are now able to shift and reallocate what the nursing functions should be. So there's a nursing team that works with the nursing staff at GPHC from Mount Sinai, and we have another team from Northwell that has also been working with them to improve nursing at the facility. So that's one component of what they've been doing. Another component has been working with the Ministry of Health in terms of looking at chronic non-communicable diseases. So we did the guidelines for diabetes, for example, where we now put in HbA1c as a gold standard. And that's important if we're going to manage diabetic patients. This year, we're working on rolling out the guidelines for cardiovascular diseases so that we can manage our cardiovascular patients better and minimize those needing to get stents and things like that. So that's another component that we've been working on. In terms of primary health care, they've also assisted in the screening tools for the school health program, and they have been helping us with the inputting of the information and analyzing the information on the school health program. So that's an ongoing piece of work that we'll be doing. And they also work with us closely on digital health and was instrumental in helping us to draft new legislation relating to data protection and some other bits of information that is needed in the area of digital health. So it's an ongoing partnership, and sometimes for you to get improvement, you need to do a lot of quiet background work that is not, you don't, really see that in the public domain. So the teams have been working with us in various areas to improve what we've been doing. So those are some of the areas that we have been looking at. And we'll continue working with them. And the work that we'll continue doing with them would include, as we move forward, a focus more on primary health care. So we want to expand primary health care, expand access, improve quality of what we're delivering at primary health care level. Our intention is to have at least 117 different interventions at primary health care. We would do a lot more work in terms of digital health and improving digital health. We're going to introduce a national quality improvement program. So one of the other things that we want, when patient comes for care at our facility, we want to make sure that they're getting good care, and we want to minimize errors in patients' care. And the only way we can do that is to constantly monitor and check to improve that quality of care that we are delivering. So we'll be setting up a national quality improvement to improve that care, a national quality improvement unit and program across the system. And they would also be working with us to build training capacity and help us to expand all the training that we've been doing. And another area that we've been working on, we've started work, we'll continue working on, is to develop oncology. So that's another thing that we'll be focusing on as we move forward.
We've heard how many you need for nurses, how many is lacking by the Georgetown Public Hospital. Can you say overall in the country exactly what is the number of nurses that we need? And in terms of, we've heard a lot about the new hospitals and so on. What about the upgrades to the current hospital? What about those, especially not just physical upgrades? In terms of administrative work, in terms of how health professionals manage patient care, because we have a lot of conflict here, a lot of complaints come to us, probably weekly, daily letters in the papers about how they view public, interface with public, the health professionals interface with the public when they go to get treatment. I'd like to know if there's any plan in place or strategy to deal with that.
In terms of what gap we have in nursing, I don't have that overall number right now for you. We have studies that we have done, depending on the different institutions, but I don't have a number right now for you. But as I said, we are working to fix the problem by training. And we have done decentralized training, so I think we are addressing the issue. The one dealing with professional conduct of staff, that is something that we are taking quite seriously. And the training that we did, so let me go back a little bit. Up to about 3, 4 years ago, 5 years ago, we weren't training people to manage facility, right? We have doctors, we have nurses, they were trained to do clinical, manage patients, but not necessarily to manage an institution. So we recognized that this was a problem. You need administrators, you need people who are going to manage facilities. And that's why we went to York University. So we have trained 60 persons so far in managing facilities, and we have deployed them in different regions. And in fact, when we took them from training, we bring them from different regions so we can build that capacity in these different regions. So that's one way in which we are attempting to address this problem. These problems, however, they're a systemic thing. So that one intervention would not substantially change everything. We got to constantly work in getting people to understand that they're serving the public. And so that's something that we're constantly working on, and hopefully you will start seeing that kind of improvement. Now, one way of holding people accountable would be this quality improvement system that we are putting in place now, meaning that professional mistakes, we'll be able to detect them and fix them before they even become mistakes. That's one of the aspirations that we have with this. And if we discover issues, then we use them to teach, and so we don't have a reoccurrence. We don't want a culture where people try to cover up things. We want a culture where we can fix these things so as to prevent these problems from reoccurring. In doing that, that's the only way the system is going to improve, right? Attitudinal problems, that one we have to deal with because we do get complaints. And one way that we have addressed that this year, we have a number that we have posted up at all the institutions. So if people have problems, they can call the number. That number comes here in the ministry, and then somebody answers it and try to rectify whatever the issues are. And if they can't rectify it immediately, they call whoever is the regional health officer so that that person can go and rectify the issues. I think that has led to a decrease in the kinds of complaints that we are getting, but we are still not perfect, right? So we still get challenges from time to time, but as they're brought to our attention, we try to respond to them.
You said that you don't have the number, the overall number, but can you get that for me?
Yeah, I think we can get that. We have some documents where we have gone through it.
Back to my question about the conduct. Do we have like a overall professional code of conduct that these persons have to subscribe to, and if they don't subscribe to them or obey them, do they get any disciplinary mechanism that is meted out to healthcare professionals?
There is, for every category of healthcare staff, there is professional conduct that is required. So for nurses, there's a whole thing there that they subscribe to. Now, one of the things, and maybe you need to let the public know as well. For nurses and midwives, if people feel aggrieved, so there are two mechanisms one can use. The more immediate one would be in the institutions where these persons are working for a complaint to be lodged. That complaint would be investigated. If that person is found to be in breach of whatever protocol, they'll be dealt with administratively, right? So that's one mechanism. The second mechanism is that the aggrieved person can go to the respective councils. So if it's a nurse, you can complain to the Nurse Midwife Council. They have, as part of the activities of the council, they can investigate these things and then institute disciplinary proceedings against that person, including taking away their license, so they can debar from being able to practice. That goes for doctors as well, right? So two options that you have. One is the administrative thing, and the other one is to complain to the respective council.
How many cases, or do you have like a number of how many persons would have been those, or would have been disciplined, or?
The one, in terms of the council, maybe you can talk to the people at the medical council. I know they're more active, and a number of doctors have actually been disciplined, including, I think this year, maybe 2 persons were taken off the register. If not 2, at least 1 was taken off the register. And that's for bad practice, right? The nursing council, I don't have the details on that, but the same mechanism exists. So I think if people are aware of these options, then it's one way of holding the people accountable, right? And we need to have that. So the quality of care that is being delivered, it would help us to improve as well. Good.
Yes, sir. It's not from the ministry. Can you speak to some of the challenges and achievements that which the ministry achieves in terms of mental health?
Mental health. So, as you know, we have upgraded the law. I think we did that in 2022. We have 2 pieces of legislation now. One that the first one updates the ordinance from 1934. What that is doing is helping us to, so there's a fundamental change with that one. In the past, it allowed us to keep patients for long periods of time. The new piece of legislation, we have to now treat people when they have an acute problem. And once that acute phase is passed and they're managed, then you discharge them. So the challenge with that is that we have a lot of patients that have been with us in some cases for more than 2 decades. Many of them, we can actually send them home. But the families of these patients, they don't want to accept them home. So that has been a big challenge for us, right? Because with modern psychiatric medication, you can actually manage the patients in a much better way, right? And so we are trying to deinstitutionalize patients. So that has been I would say one of our biggest challenge for this year. And I foresee that being a challenge as we move forward. Outside of that, I think in the area of mental health, we have made substantial progress because a lot of our efforts were at Georgetown Hospital and at New Amsterdam. We now have at least mental health services in almost all the regions because they have, where we don't have a psychiatrist, we have doctors who would go out into the regions and do that coverage. So that has been an improvement. The second service that we are offering is that we are now able to offer mental health services for children because we have 2 child psychiatrists on staff right now, and they're able to offer that. And then the third option that we have, through our telemedicine platform, we are also able to offer mental health consultations. So the unit at the Georgetown Hospital, any one of our telemedicine facilities, if they have a problem, they can talk to one of the psychiatrists there and they would be guided. If they need that specialized service and need that person to come to Georgetown, then those arrangements are made. So that's another option. We have been able to do a mental health strategy with the help of a consultant from India. And we are in the process of rolling out that strategy. We have done quite a number of training, especially not just for our staff, but we have been working with the media as well, because how these things are portrayed and reported is very important, right? Because you can convey the wrong impression, especially for persons who are probably contemplating suicide. So that can be a challenge. This year also, we have rolled out a program to train primary healthcare physicians to be better able to diagnose depression. Because there's a correlation between depression and people attempting suicide. So we want, when persons come to the clinic, that these questions are asked, and we can be able to detect and then help to protect those persons. So that's another program that we have. And through Canada, we have had the Canadians funding IDRF. That's a Canadian NGO. And they have been able to train close to 600 persons in the community to be able to detect people with mental health issues and to be like gatekeepers. So they would be the first one to interact, and then if they feel this person requires additional service, to then be able to channel them upwards to us. So I think these are all positive initiatives, and in different ways they're going to help. The Adolescent Health Department in the ministry also did another innovative kind of intervention in schools. Something that was tried in Africa, where there were some benches. I think they were painted in green. And if a child has a particular challenge, frustration, whatever, they go sit on the bench, and then someone who's trained would go and engage them. So this was successfully implemented in Africa, and we have been experimenting with it here to see whether we can get similar results. So, we're working on different strategies to make sure that we can reduce the burden of mental health illnesses. I think, however, the big challenge, though, is that quite a number of mental health patients some of them are patients with substance abuse problems. And we have 10 clinics that we run to help persons with substance abuse problems. But that's an area we need to develop more, because we don't feel that we're filling all the needs. And in the new year, that's something that we'll focus on some more.
What is the ministry's plan for when families of the patients refuse to collect the
There's not much we can do. We'll probably have to make alternative arrangements to see whether they go into a home or something. But it has been a challenge for us, because a lot of our beds that we need in the hospitals that are very active, a lot of those beds are occupied by patients who can actually go home. So it's a challenge. I don't know that we have a perfect solution for it.
One more for me.
Sure.
The Public Health Act, a new Public Health Act, we spoke about this in
Mhm.
2023, and you said that work was ongoing in the drafting of this new act. Can we get an update on that?
Still in a draft form. And the reason being, it's actually a very big bill. And it's something that we are attempting that it's quite new. Because what we are trying to do, we have right now about 9 different chapters. Each of those chapters about between 50 to 100 pages. So you can imagine the size of this bill, right? And it covers everything from how do you regulate things like housing, environment. So it's a massive piece of work, and it's multi-agency. So therein lies some of the challenges, because before we confirm anything, we want to make sure that we are aligned with the different agencies that would have to implement it. So it would still require a lot more consultation, but the first draft is there, and we'll continue doing those consultations as we move forward.
Thank you.
I think there were anything else that we missed? I think I had another one that. Maybe something that would interest you as well. Somebody had asked, but I didn't think I fully answered it. I don't know. In terms of some of the other things that we're doing at the existing facility, right? We have added a number of operating theaters to different facilities. So, for example, Maikoni Hospital, we have added a theater at the Maikoni Hospital. We have added one at Port Kaituma. We have added one at Anai, Karasabai, Sand Creek, and Kokwani. So these are new theaters that we've added, and they would be completed soon so that we can commence operation. The one for Maikoni, this is already operational. We have also been doing more surgeries across the different hospitals. So since we have opened Maikoni Regional Hospital, the theater there, we have completed for this year 296 surgeries. Diamond Diagnostic Center, the Diamond Hospital, we did 150 surgeries. Westdam, we did 1,278 surgeries there. Suddy, we did 662 surgeries. Linden, 938. Lethem, we did 1,106 surgeries. And some of these surgeries are not only for Guyanese, but people who come over the borders. We have been facilitating them. Madhya, we did 24 surgeries there. Mabaruma, 325. Kumaka, 120. New Amsterdam, we did 1,242. And Bartica, 150. So in total, with these hospitals around the country, we did close to 6,291 surgeries. That's leaving out the work that we do at the National Ophthalmology Hospital, where we did 2,560 surgeries at the ophthalmology hospital, which include 883 cataracts. Anything else? Mm-hmm. That would include those from the GPHC. So basically what happens is that sometimes we don't double count, right? So it might originate from, let's say Region 1, what was referred to GPHC. So while they might tell you that it's a death that occurred at GPHC, if it wasn't a patient that they managed, that is then counted as a regional death, right?
Good morning, Mr. Robert Williams from Guyana Times.
Mm-hmm.
In September, during a high-level meeting on antimicrobial resistance at the United Nations General Assembly, you would have noted that AMR has resulted in a significant amount of deaths, even surpassing scourges such as malaria and HIV. So my question would be, were there any recorded cases of AMR in Guyana this year? Also, is there any program to train professionals to deal with AMR cases? And lastly, in an effort to tackle this issue, you guys would have stated that you would have been cracking down on drug distributors distributing antibiotics without a prescription. Have anybody or any persons or drug distributors been charged so far for this?
Yeah. So AMR is a growing problem that we have. And the reason, not only Guyana, it's not a Guyana problem alone, right? It's a worldwide problem. The reason, and I want you to think about this, the reason why this is a problem is that pharmaceutical companies are not investing a lot of money in doing new antibiotics, right? And even when they invest the money, they, if you're going to hold those antibiotics in reserve, right, meaning that you're not using them as the first line, then the chances of them making back the money that they've invested would take a longer time. So for many of these companies, there's not a big incentive to invest in newer medication. And what we are finding is that the existing medication that we have, the pathogens that are circulating are becoming resistant to the existing medication. So sometimes when you are in a hospital, that's why they have to run these drug sensitivity tests. Because while you can treat with antibiotic A, and in some cases you get good results, in other cases, when you're treating with that same antibiotic, you're not getting good results because that patient might have had some resistant pathogen. So we are starting to see some of that here. And we'll be monitoring to see what types of resistance and so forth that we are finding out. Because this is such an important problem, because imagine if none of our antibiotics are working, then all the achievements that we would have gotten fighting infectious diseases with antibiotics, all of that can be eroded, right? So that's why we now have to use these things more diligently. Not everybody with a cold turn up at a pharmacy and you get some antibiotic. That's not going to work, right? Because that's only going to promote resistance. So the ministry, we now have an AMR strategy that we sat this year and we worked on, and that document is available. And it's a multi-pronged strategy. So in our institutions, what do we need to do to reduce the spread of infections in our hospital? That program is called an antibiotic stewardship program that we are introducing. We have a focal point responsible for AMR in the ministry, and we are going to roll out this antibiotic stewardship. So that's one component. Another component got to be with the right use of antibiotics. And so that what you spoke about with pharmacies, that is something that we have to do more enforcement on. And I already spoke to the Pharmacists Association so that when we start taking action, one of the likelihood might be that we'll have to debar people if they're not prescribing properly or they're not adhering to the prescriptions, right? So this thing is going to be multi-pronged approach, but it might fascinate you to know globally that the biggest users of antibiotics is not necessarily in human medicine. Some of the biggest users of antibiotics are actually in agriculture. And so with a comprehensive program, it would mean that we have to address antibiotic use across the board, how it's being used, where it's being used, what can be done, and how can we minimize the use so that we don't develop resistance, right? And again, that's going to take some time for us to really work and develop that.
Do we have any other questions? No?
All right, so um, Hmm? Okay, so I think for us, as I started, I said this year we have had a very successful year in terms of the programs that we are implementing. Already you're seeing that we are doing a lot of new things. So it's not just what was there before. We are doing new things. We are doing them qualitatively better. We are expanding them so that more people can have access to the services that we're providing. In all the regions of Guyana, we have improved the infrastructure, whether it's a health post, health center, hospitals. We have improved all these things, and we are adding new hospitals. So with the new hospitals that we're working on, every region would have a better quality facility. And the hospitals, you will see them come at different points. Next year, we'll have the 6 that I spoke about. The following year, we'll have some more that would be opening. And then with the 3 that we are working on right now, Maruka, Keto, Letem, those would come into play by 2027. And there are others that we're working on. So you would see us over the next couple of years improve our hospital infrastructure, and it would only lead to better outcome for our patients. You have also seen that people now have access to better surgical care because of the amount of theaters that we have around the country. People have better access to x-rays and imaging services because we have changed out. In 2020, for example, most of our x-rays were analog x-rays, meaning you had to use a film and wash the x-ray and then hold it up and see what's going on. We have changed out all of those analog thing. We now have digital x-rays. So that is now available. And we are using a PAC system where we can send those images to Georgetown Hospital for interpretation because they're digital. And in the next 3-4 years, we will add at least 14 new CT scans to the public health system. Within the next 2 years, we'll be adding MRIs into the system. And by early next year, we are adding 4 new mammography machines to the system. So all of this would enhance the way that we can do diagnostics, and it would really improve the quality of care that we can offer to our patients. The specialization training that we're doing for doctors at McMaster's, a lot of those doctors, when they come back, they'll be able to provide high quality specialized care because we have chosen some of the fields that we really need, and we have sent these persons to training. Through this program, we'll have at least 30 of our physicians being able to specialize in different fields. And so they'll come back and work with us. So I think when you look at the investments that the government has been making, these investments are really going to change the quality of medicine that we are practicing here in Guyana. And already we are seeing that people from other Caribbean countries are actually coming to access care in Guyana. We have patients who come for different things, and we are able to provide that care for them. And as the system improves, we expect that many more people are going to come here. I'm sure when GPHC presented, they spoke about the joints that they are doing at GPHC. So things like knees and hips, we do them now routinely. And in many countries in the Caribbean, these things are not even offered. So we are now doing a lot of the types of surgeries that we're doing. And we now take them for granted. Weren't there before, just maybe 2 years ago, 3 years ago. We weren't able to do that. So we'll improve the sophistication of the surgeries that we're doing. We are moving away from doing a lot of these open types of surgery to using what is called minimally invasive surgeries, using laparoscopes and things like that. We are buying the instruments to facilitate that. And there's a lot of changes in how we're practicing medicine. So people can expect that the system is going to improve, and the quality of medicine is improving. And despite our challenges, our human resource challenges, we are working to fix that as well. And we feel that with the things that we have put in place, that institutions such as the Pan American Health Organization and other institutions are looking at us as a model for what can be done in other countries. So in health, I think this year's achievements speak a lot for itself. And I want to commend all the staff of the ministry, the hospitals and so forth, who have worked on this, because it's their hard work that we are celebrating today. Thank you very much.